So we will start with, thank you, Dr. Lewis, for coming. I appreciate you being here. I understand you have some information you wanted to share with us just on COVID. I think Heather, you may have visited with them. So if you could just take a few minutes, and I think we'll take questions from the rest of the board.
Well, that sounds good. Let me introduce myself to the room, to the board members of the room. My name is Kevin Lewis. I'm a physician by background. I'm a long and intensive care unit specialist. I currently serve as the regional president for physician and ambulatory services for SSM Health. You may know SSM Health in this region as St. Anthony, or the St. Anthony Health System, or SAINS. And I'm a Southern Nazarene University undergrad, and so, and two daughters have, one's there, one's graduated from there, so lots of time in the Bethany area. I was approached about, potentially being here just as a healthcare resource for what is going on in the community, and so I'm thrilled to do that. We're a faith-based organization, St. Anthony, SSM Health. So our mission statement is, through our exceptional healthcare services, we reveal the healing presence of God. Our emphasis is healing presence, and part of that means to make sure that we're integrated with the community and trying to be a resource, whether you need one of our clinics or hospitals or not, just trying to be a resource. So I gladly said yes, that I'd be happy to be here to be a resource and to provide information. And then when I thought about that, I thought, well, that's a little bit nerve-wracking, because you need to know I come with no agenda. I'm not an educator by background, although I'm married to one, and I'm the son of one, and care deeply about that process, and also, in postgraduate education for doctors and so on and so forth. And so, as a community resource, we just want to, from a public health perspective, and to help people understand what we're seeing on the front lines, and hopefully not have it be a politicized conversation, but just share from that. So for the most part, I want to maybe field questions and provide clarification. But there are a couple of opening comments. There are lots of resources out there. Most of them are consistent, but some of them conflict, and so that's led to a lot of confusion, whether it's, do we believe the CDC? Do we believe these other resources? Do we believe the state or community level health department resources? And so physicians oftentimes have other resources that are sort of straight from the doctors. And the group that has put out the most information on how they feel about school has been the American Academy of Pediatrics, because pediatricians are most likely caring for school-age children, have a great stake in how does that process go, a great connection oftentimes with school nurses, so on and so forth. So the American Academy of Pediatrics really put out a lot of information, particularly going into the fall, as to thoughts and approaches about in-person versus virtual versus hybrid versus any number of different types of approaches for our students and our faculty or teachers in that regard. But the thing that the medical community put out in that process was, we want safety to be paramount, but we would like folks to approach this from the bias of, start with the bias of how do we get to in-person learning because of the true developmental and social and mental health needs, and I can go on and on and on for a child, but also do that in the context of the environment that we're in as it relates to COVID-related activity. Some of that is subjective, and so that's really for each administration and decision makers and so forth to come to together. Some of that information, though, is objective, and it allows us maybe to put our emotions aside a little bit and try to use more raw information to try to make decisions. And so I, as a physician, kind of come at it from the bias, and I want to share it as a bias, right? So I'm not trying to share any of these things as fact or so forth, but the bias is, the physician bias is, if it can safely be done, can we move to in-person learning? If it can't safely be done, what do we need to do as the next best thing? And when is it appropriate to get back I share that not from a personal agenda, just so that you understand the mind of the physician or clinician. Knowing that we're not in the position of decision maker to have to make this come to fruition, there are a lot of stakeholders and a lot of constituencies. So knowing that this system was grappling a little bit with that, Heather Wheeler had reached out. Others who are not part of the decision making from other school systems reach out frequently and ask questions. And I said, I'm happy to answer questions, but everyone should always bear in mind that I am one individual, right? And there are some nuances to this, and so there's other feedback that others may want to get. But I come from a specialty background and come from leading a health system to where we are seeing exactly what's going on. And I spent a lot of time on this topic, as you can imagine, and so if there's a desire to have medical input or medical resourcing for these decisions, happy to provide that. So that's a little bit of prelude, but I'm going to be better off at maybe answering specific questions that you would want answered, because there's no intended presentation here. It's really to be a resource.
I'll take that. I'll ask you a question. Okay, Dr. Lewis, we've all received a lot of feedback from our community about different fears. And I think from the perspective of our teachers, many of them are very concerned that they will contract COVID, potentially from a student, and give it to an elderly person in their life. And that's been one of the big concerns. And so we are trying to balance, as you said, our constituencies. We're trying to balance what's best for our students. We're trying to balance what's best for our staff and our teachers. What would you say to that?
That's not a loaded question.
Yeah, sorry. Here's mine.
Yeah. So that is
Would
part.
that be one of our biggest questions?
Yeah.
Yeah.
So the stakeholder groups are multiple, right? Starting with the reason that the system exists, which is the student, and education. But the educators are the vehicle through which that absolutely occurs. And so each stakeholder group has a certain concern or fear, or in some cases a lack of fear. We all kind of had our perspective about this, and they bring that to the table. Bear in mind that from a community perspective, the potential for exposure to the SARS-CoV-2 virus and COVID-19 exists all over the community, all over the country. We certainly are seeing that level of spread right now. So there's no foolproof way in any environment to say that just because I am or am not going to be exposed to it in the school environment, that I am or am not going to be exposed to it in all of the other environments of my daily life. Whether that be the store, whether that be the worship area, whether that be, I could kind of go on and on and on. And so it's very hard when we get asked this question of, well, is this environment worse than this environment, worse than this environment? Well, there are some that we do have pretty good evidence that those environments are more potential for super spreader than other. And it really has a lot to do with, are folks going to be unmasked in that activity or behavior? Some examples that you may have seen or heard a lot of, whether you believe me or not, right? A more crowded restaurant or bar scenario where everyone is masked off and so forth, depending on the ventilation, there's lots of great case reports and evidence that that's a potential environment for super spreader. So I've had one educator talk to me about their concerns about the school, and I was like, well, is everybody in mask? Has everybody done good things with distancing? Is everybody focusing on hygiene, other things? Yes. I said, have you been to a restaurant during this pandemic? Oh yeah, which one? Oh, Louis. It's like, well, I had to walk into a Louis and walk back out one time because I was like, oh my goodness, this is a little bit concerning. So there's certainly some relative risk in that regard. Gyms and areas where athletics are going on, people are unmasked, breathing much more heavily. These are the types of examples we get out there. So part of it is, what other mitigation strategies are involved? If there are a lot of other good mitigation strategies that have been involved, even in this sort of a setting, if you're able to feel like you can control for that, that's a great benefit. It provides a lot of assurance. Does that eliminate any risk of exposure? It doesn't. Right now, until we get through a much better vaccine administration, there's not a way to completely eliminate risk. But there are a lot of ways to mitigate that risk. And one of the things to do is not just assume that's going to happen. We advocate for schools and other organizations to monitor very carefully their own internal community, not just the county, not just the city, but what is actually going on if we're monitoring it on a daily basis in our community in terms of exposures, positives. Were those community-based, or do we have horizontal, what we call horizontal or lateral spread within the community? Do we have evidence of that? And so we don't want to be terribly reactive, but at the same time, if you assume that there's going to be a major issue that may not be borne out by the data. So I may have talked all around that. The fears and the concerns are out there, and we get all of that. But in a metropolitan area, they're in every facet of your life. And so in some facets of your life, you aren't able to mitigate your risk. And in certain facets of life, everyone is focused on mitigating the risk so that they can be in person. We have some pretty good evidence that those mitigation strategies really do help. And if folks are monitoring and saying, we really are seeing a change in pattern, we need to back away, then that's the use of research and data to make decisions, as opposed to maybe making decisions based on a little bit more on emotion.
Dr. Lewis, for the longest time, when we got into this process of kind of, as we, I think back to June or July when we first kind of developed a system of saying, okay, where are we? We used the county color code system, right? And the one thing I would say as a board that we adopted that, we added to it that not only were we going to look at the color code, but we also were going to look at some circumstances within our school to make sure it was okay to be here. We actually were in a situation where we stayed in that yellow and that orange throughout the fall, and then as we got into November, we actually moved into red. Yet we made the decision from an administration standpoint, and the board agreed to it, that we would go ahead and stay in school. Okay, we felt like we were safe and we were fine to do that. And so the one area I wish we would have done as a board is when we adopted this color coding system, I wish we would have taken that next step. We can all look back and say, we wish we would have taken the next step. If you look at data points, what might be some of those data points we should be looking at other than just the county as a whole?
Yeah, well, part of it is how good is your data, right? When we talk about data analytics, it's if it's garbage in, then it's garbage out, and you can't make good use of that. But if it's reliable, then you can. One of the challenges you're faced with and other systems are faced with is once you try to get down more granular than the county level, can you get access to that data in a timely fashion to make decisions or not? There is zip code level data, and we actually, in the Saint system, have been monitoring zip code level data together with the overall Oklahoma City County Health Department and county data. And the reason is we were trying to figure out, so across the metropolitan area, there's not an equal distribution of COVID, okay? It is in hotter spots than others, even within the county. And so in different months, different hospitals have had much different rates. Now they're all much fuller now, but earlier on they were wildly different rates, and we could not understand why that would be. But when you got down to the zip code level, you recognize that well, my goodness, we're higher now because the zip codes nearest to us actually are where the bubble plot is much thicker right now. So we've learned more, at least as a health system, in anticipating what we're in for when we've monitored zip code level data for the positive cases. Once you try to get beyond that, it really gets fuzzy and messy, and it's hard really to get at that a little bit better. Our county is huge, and as you know, Oklahoma City, I think, still is second only to Jacksonville, Florida, in terms of land mass of major cities. So you've just got all this spread out area here, and COVID is not equally distributed. So if I was to say, okay, in this county, let's look at the number of positives per 100,000, that is one data point. But for an isolated school system, whether it's in a certain suburb or connected here or so forth, what's going on right around you is really a little bit of your community spread. That is, of course, can be polluted by the fact that I work there and I live here. So there's no way to get it pristine. So, sometimes you can use both data points. We like to take it down a little bit further. And I think the zip code data, especially for a district like this, may have a little bit more use or help, may not. It can depend a little bit on where people work and play, as well as what's right around here. That was a bit of a long answer, I apologize, but I hope it's helpful.
No, thank you. Yes.
What is the best place to get that?
Well, the question is, what is the best place to get that? And that still is available. You have to do a bunch of drill downs, but that actually is available through the state site in reporting.
Okay, so that is accessible to us, so we could use that to inform.
Yes, so in fact, we actually have that information for tonight, and the State School Board Association made that available, as far as I could tell, last week. They provided that where it was more easily accessible from the State Department of Health. So we do have that information, and I think maybe later, and Mr. Drummond may talk to us about that, about bringing that information down so that we can look at and see. Like, for example, and we'll talk about this when we look at the matrix, but we do have over 1,000 of our students and our staff who are in this zip code, and the case count per, the average per 100,000, the case count is about 3 times currently what the State Department of Education said would be the top level to be in the red. And so our zip is already like 3 times that.
73008?
Yes.
Okay.
And that's where over half of our people live. So anyway, that's something that I totally agree with. We need to look at that. And so that's good, rather than just the county. I did want to ask you, Dr. Lewis, what do you see, what is a factor that we as a school should consider distance learning? I know we want kids to be here, and that is, everybody's desire. We want our kids to be here face to face. But is there any point where you feel like, as a physician, it is not safe? Is that when we have 50% of our kids who are sick, or what do you think?
Yeah, so another loaded question, I appreciate that. We just to tell you, in medicine, as we look at what we call epidemiology, right, it's the course of disease activity in the community and so forth, we tend to look more at the trend as opposed to the absolute, because we want to be out ahead of mess. Okay, so I would encourage you to think about, that's why if you look at some of the CDC recommendations, and no matter how you feel about the CDC right now, there are some good recommendations that are out there, but many of them actually focus on what is going on over the past 7 to 14 days in a trend, as opposed to an absolute value. And so I'm encouraging, both in terms of what's going on in the community around you. That's just one data point. It may not actually be what's going on in your schools, right? And so they don't equal each other necessarily, because even in the same geography, certain populations or more at risk than others. So what is the trend? You can use a 7-day, you can use a 14-day, you can even use it shorter if it's an abrupt trend. But what is the trend of spread around you? And then what is the trend in your actual student and teacher activity? So one of the potential grids and frameworks I saw was, an absolute number. And so an absolute number, if that's going down from where it was, actually may not be a good signal because you're in better shape and in safer shape as long as you're doing the mitigation strategies. Whereas if you're in a bloom within your system, you'll want to consider. And so we look at sort of what's that doubling rate, right? So if I went from 2 to 4 to 6 within a week's time, we really need to look at that. And so I would encourage you, and you have some math whizzes to help with that and so forth. But I would look at trends rather than absolutes. Are you increasing? If you're increasing, get out ahead of that, or are you not? Because if it's 5 throughout the system and it stays at 5, well, we may be very fortunate that that's the case. So the trend line can be very, very helpful, because if the going into COVID and coming out is about the same, when you have a highly infectious agent that should be doubling at a rate of 2 to 3 exponentially in terms of that, if you're flat, that's actually a pretty good sign that your mitigation strategies are working. So I didn't give you a hard math answer other than I would encourage you to look at trending as opposed to absolute values to really get an idea of where you're going when you need to vacate and move to distance learning only. If you can find one you like. I mean, that becomes the new debate, right? What should that be, and what should that look like?
Anybody else have questions?
Okay, I have a question for you. One of the things I called specifically to talk to you about 3 weeks ago, so that Dr. Lewis and I have been friends for many years, and I just felt like I needed something to inform me more. And so when I called you, one of the things that was such a concern too was the ICU beds. One of the things that was driving this was, people were so concerned about ICU beds, potentially taking one up, not having one if they needed a bed. So there's this number going around that 95% of the beds in Oklahoma City are taken up. Can you speak to the situation in ICUs? Can you give us some kind of context for that information?
So the question, just for everyone to hear, was the ICU bed situation, and that was a consideration for everyone as to what's going on in the healthcare system and using the ICU beds or ICU bed availability as a barometer for making other public health decisions, whether that be the public health of your school system or other types of things. And so there's been a major evolution around ICU use and ventilator use and so forth as we have learned a lot through this pandemic. So for instance now, some of the bigger concern is just the COVID beds that are not ICU related, because we are doing a better job of treating people, and so fewer are going into the ICU. Or in very high-risk situations, we're doing a lot better about having appropriate end-of-life conversations with people to say, do you really, with this survival likelihood or not, do you really want to be on a mechanical ventilator in an ICU and those types of things? And those decisions are allowing resources. So better resource utilization. So what we are really looking at is the overall COVID percentage in your hospital, regardless of the type of bed use, as a better barometer for what's really going on in terms of the activity and so on and so forth. And we're trying to wait as long as we can before somebody goes on a ventilator, because that pressure in the lungs actually has the potential to create some injury. So the longer we can wait. Well, if we can wait long enough, we can do fairly high oxygen flow in other environments without having to come in to the ICU bed. A final thought there is that it's not just about we have the beds. Major hospitals in this region have had to basically create 2 hospitals in one. An area where we have units that are fully dedicated only to COVID so that we don't have cross-contamination to other people who need necessary care. We've done a remarkable job. I'm not just talking about our organization, I'm talking about all the major health systems in Oklahoma have done a remarkable job of preventing transmission from a positive patient for SARS-CoV-2 virus and COVID to others. So what happens though is I can't take somebody who doesn't have COVID and treat them in a COVID unit, and vice versa. So our bed availability is more limited because I may have an open bed, but it may not serve your need because you do or you don't have COVID. So our total beds actually give a better idea of where we really are and what the likelihood of being overwhelmed is, which then impacts can people get care when they need it, whether it's for COVID or whether it is for some other things. So in the health systems, yes, we're keeping track of ICU, yes, we're keeping track of non-ICU, but we're paying a lot more attention to the statistic of percent COVID within your hospital, which gives you a better indication of what is the COVID burden on the hospital system. One final thought, an ICU bed is not an ICU bed is not an ICU bed when reported in the state or even when reported in this community, right? Why would you say that? Well, if I'm in a certain rural community that has 5 licensed ICU beds, but no one to really be able to take care of safely a very, very sick COVID patient, those ICU beds stand out as 5 ICU beds available in the state, and they'll never get used. That community or rural hospital will always be sending to an advanced, larger, what we call tertiary care system, like some of the bigger hospitals that you're familiar with that are more used to taking care of this and so forth. So just purely bed statistics aren't helpful. We always have to use what are called staff bed statistics and pay more attention to the larger facilities and where they are, because most of the smaller facilities are transferring into the larger facilities. In fact, we're having to beg smaller facilities to take people back once they're getting a little bit better so we can preserve room in the larger hospitals. I know these are long answers, I just want you to understand our thinking is evolving, and I used to pay a lot of attention to ICU bed availability, and we've actually stopped paying attention to that quite as much. It's overall burden of COVID.
Is that what's stressing the metro hospitals?
Yeah, the overall burden is what is stressing the metro hospitals, and what I mentioned is it affects our throughput. So if I can't put somebody who's sick with another issue into a COVID unit, they just basically sit in the ER until a bed in the non-COVID areas opens up, and vice versa. So your entire logistics and operating model changes because you can't make full use of all of your facilities the way that you normally would, because you have to separate everything.
Yeah.
Dr. Lewis, when in regards to hospital beds, I know that there was a time back in the spring where I believe like elective surgeries were shut down, correct?
Yeah.
And we're not at that point right now where electives are being shut down in the state of Oklahoma, are we?
We are at the point where they're being delayed frequently. Because what happens is if a certain type of surgery needs a bed after the surgery, and you can't assure that you'll have one, you can't safely take someone to the operating room knowing that you can't. So we basically have to ration the number of surgeries right now each day to make sure that we have a bed. One thing for the public to understand is we use this term elective surgery flippantly, and that doesn't mean what everyone thinks it means. So an elective surgery means something that you didn't have to get rushed to the operating room in an instant or emergency to save your life. Well, once you take that off the table, all other surgeries have a different level of seriousness or severity, even if it is not in an emergent situation. The elective simply meaning we could schedule it. Well, if you're going to get scheduled for an open heart bypass, that's a big deal. But it's technically an electively scheduled if you're not in an emergency situation crashing, from a heart attack. Well, that's extremely different than I need my knee worked on at an ambulatory surgery center and I'm going to go home the same day, where I don't need a bed. So the Hospital Association, they've been really trying to educate the politicians on, when you say elective surgeries, we can keep an ambulatory surgery center running. They don't need a bed. They're going to go home the same day and convalesce at home. So there are different types of surgery. But if somebody needs a bed, we are having to ration that to make sure that we have a bed. Because remember, if they are fine, I've only got so many non-COVID beds because, again, we've had to separate. Normally, I would have said, boy, I've got all this access to all this different. Does that make sense?
Yeah, that makes sense. So if we were to get to that point where we needed to no longer even delay some of those, who is qualified to make that decision, or who would be making that decision to close those hospitals because of that we just aren't going to do any of those because possibly of all the COVID cases?
Yeah, so really we would hope that state healthcare leadership would advise. The only person that has the authority in a public health emergency to require that is the governor. We would hope that the governor is getting the right advice. The governor and the hospital association have tried to work together on this to appropriately deal with that, and that's how they came up with the tiering system of, if you get to a certain percentage of COVID in your hospital, we're going to phase kind of those delays and try to avoid this all in. You've got to stop doing surgeries, but rather, what is your pacing? How do you delay? How do you stratify? How do you use that? So the State Commissioner on Health and the State Department of Health would have a lot of input there, but they are reaching out to the Hospital Association to try and work collaboratively with all the major hospitals in the state to get that right. Now, one of the things is people say, well, should we use the hospital situation and decisions to determine school-based decisions? Well, we can't automatically make that extrapolation, right? More than 75% of all hospitalized patients are above the age of 65 in the state of Oklahoma with COVID-19. So, all of the decisions about what we're doing from a public health perspective are in hopes of, mitigating those issues with hospital capacity and so on and so forth. But it's not immediately extrapolatable that if I do this in this place, that's automatically going to help the hospital situation. For instance, Thanksgiving get-togethers, I would have told you, have a much bigger impact than maybe any of these decisions on the potential for that to really spike. Because it's really the spikes that get us each time we get into that, and that's why I say watch the trends as much as anything.
Anybody else?
One other question, I'm sorry to hog the mic. Is anyone else? One other question I had was, I know that when you visited with Heather, you sent out some information to us from the American Academy of Pediatrics, and Courtney, you were kind enough to pass that along. I'll be honest with you, Dr. Lewis, she sent us the Cliff Notes versus what was sent to us. It was one thing for me to read.
That was a smart decision.
And as I read through these, there was a lot of talk in there about, really, they're suggesting we need to be in school. It seems as though that's what they're doing. They talk a lot about social distancing, and they 3 to 6 feet. It's my understanding we're doing, at A to B, we're doing a 6 foot, and so we're wearing masks. And so when I look at some of these things, and with what you're hearing in, one of the big concerns that I know parents have is the collateral damage that's being done with these students that are being out from mental health to abuse to, I mean, it's a laundry list of just nasty things. Can you speak to that at all, or is there, I mean, are you hearing that? You're hearing a lot of that, I'm sure, in some of your stuff.
Yeah, in our group, we have a lot of pediatricians, and I actually employ a lot of pediatricians and sought, particularly in the summer, certainly in the spring, as everybody just sort of hit the reset button and we closed everything and tried to get our wits about us. So, but as we went through the summer and then into the fall, there's a whole lot of conversation about everything that our pediatricians were seeing and what their expectations were and how they were trying to answer questions for various school districts and parents and so forth. What should we do? But it was interesting as you would get to back to school visits and all those other types of things as you got there. So it was pretty staggering what our pediatricians were sharing, obviously not using any confidential information or so forth, just giving general concern about, wow, these kids just aren't quite the same. We're really concerned about them. Can you give me any specifics around that? And it's a little bit difficult because until we get all of the research, and right now research has been limited because all of the focus around research has been more how do we solve this infectious agent and get to the other side of that. So folks are really starting to try to build research studies to try and get a better handle on developmentally, psychosocially, mental health, substance abuse. I'll be really fascinated to see what testing and what some of these other things look like over time. Many of those we won't know until we look through, one of my mentors used to call it the retrospectoscope. And so until we look through the retrospectoscope, we won't know some of those things. One of the things that I can tell you though is that at least in our pediatric group, referral for mental health services for, especially in the adolescent age group, has skyrocketed. And that's just I can't speak for all the other systems. I just know that our systems, our biggest concern really fits in that particular category because we're just seeing it quite a bit. The other thing to know about the St. Anthony system is we're the largest provider of child and adolescent inpatient behavioral services, not just in the state of Oklahoma, but in the entire Southwest. A lot of people don't know that about our system. We have huge behavioral services for those that are having a need stream. And we are seeing an extraordinary demand for that right now, beyond what we ever had, and we only have so many beds. So we're certainly seeing it. I couldn't give you great statistics just yet. I think only time is going to tell around that. But it was that trend line that pediatricians around the country were seeing that was like, we have to be safe. We grant that, and we want everyone to make decisions, but we do want to put out a statement that says, please bias yourself toward creating a sense of normalcy to as much as you can. Now, wearing a mask tonight, and the way we're all, none of this feels normal, right? But is there any way to create as much of that as possible? And that is a tough ask, right? Because what is that balancing act? And there is tension there, and I acknowledge that. There are just going to be consequences out of this. There are going to be consequences for the adult patients too. Those who have deferred care, those who have mental health issues, substance abuse is crazy right now.
So that brings up a question that I had. So you mentioned, of course, there are obvious mental health issues that are going to be related to kids and teenagers. Do you see the same instance with adults and mental health issues? Do you have the same referral trends? Or is it just younger people, just teenagers and school-age kids? So they're not an anomaly, are they? Or is it everybody? Does that make sense?
They're not necessarily an anomaly in the regard that across the population we're seeing more issues. There's a difference in how it manifests. So in the adult population, you may see more depression and substance abuse and so forth. In the younger population, levels of anxiety and generalized anxiety disorder tend to types of things. I think the reason why folks are concerned maybe about the younger population, nothing against us adults, is that if that is impacting now, and it otherwise wouldn't have, the years-long trajectory without intervention is very concerning. So it's what are you going to get as you move through the stages of development and then on into adulthood is, I think, where that comes from. Because there's so much research showing what that looks like if we're having to deal with it. So, but I need to be fair, it's across every aspect of the population right now. So if I was talking to a big employer, I'd say, yeah, work from home is a strategy, but I might encourage you to figure out how to get back to work if you can too. If that's possible, be safe enough. For the same reason.
So I had a conversation with a pediatrician today, actually, and he shared, and I just wanted to confirm your take on this, that generally kids as they age over 10 or 11, we're seeing the transmission rates are higher with that population, but that the like under 10 transmission, they just maybe don't have symptoms or transmitted. And would you agree with that general take?
So far, the available research suggests that that cut point is around that 10 or 11 year of age, where the likelihood to develop symptoms, if one is going to develop, starts to go up above those ages. And the likelihood of transmission, it's been really fascinating in that elementary age group, is not only do they not have symptoms, they do not appear to be driving a lot of transmission. We don't know why they're not giving it away as much or giving it away at home or whatever. And after you start to get to that middle school and high school age, there's more potential for symptoms, even if they're super mild. I mean, they typically are asymptomatic too, just a slight change. And the potential for transmission to each other goes up. It's fascinating. Really, people would ask me in the fall, is school driving all of this as we started to see that going up? And I said, believe it or not, I think the evidence is going to suggest, and we may have to look back on it, it's more the college campuses in that age group that actually is our primary and secondary. Both from a standpoint of risk-taking behavior, which is more predominant in those age groups, but also it's just you need to kind of get into that later adolescence to adult to start having transmission rates that look like other adults. So there's a trajectory over time. And that's why folks are saying that you might be able to approach it different at the different ages because there are distinct differences. And that makes it more complicated for schools as opposed to a one-size-fits-all, but very different in the younger youngs. That's a good question.
Well, I do have a question. I'm gonna put you on the spot and say, you don't have a crystal ball, but we're sitting here, it's December, mid-December. What do you see the rest of the winter being like into the spring? Do you have a feeling on how that's gonna go? Can you speak to that?
Yeah, so the question, just to reiterate it, was what does my crystal ball say? And it's as hazy as everyone else's is, of course. But what does my crystal ball say maybe through the rest of the winter, and what might we be looking at in the spring or summer? It's helpful to receive that question after a vaccine has been approved under emergency use authorization and is starting to be distributed this week, because that changes things rather dramatically, especially if the uptake of the vaccine is at least 60% of the population or so forth. December and January are going to be tough just because of where our numbers are, and we're in the winter months. We are so fortunate that we're not really having much of a flu season at this point, and we think all the mitigation. Flu is less contagious than COVID is, and so when you do all of the things like we're doing tonight, it actually has a huge impact on flu transmission, even if it was around. So we think that may be part of what is going on. So as long as we don't have a flu spike together with what's going on with COVID, I think we can get think we can get through it. But if you look at where we are, and you look at holiday activities, and you look at other things, December and January will be, they'll still be challenging. I'm actually extremely optimistic post-January. The reason I say that is we already know what our distribution amounts of some of the earliest vaccines are going to be. And so we'll have the majority of high-risk healthcare workers and long-term care facility folks vaccinated who are willing to take it over the next 6 to 8 weeks. And after that, we'll be able to start to go to the high-risk public. And in the phasing strategy, there's an appropriate place for the education systems in that phasing strategy and so forth. And the major math models that look at this pandemic that have been closest to accurate to this point are showing really interesting changes based on when they plug into the model the impact of vaccination at about a 50 to 60% uptick by March, April. So I'm almost of the mind, if we can figure out a thought process for December and January and get through those months, I really actually believe that February on starts to be a much better conversation for us. I could not say that if we didn't have the vaccine situation that we, that we're able to talk about.
Well, yeah, and you and I talked about herd immunity, which you felt was a strategy in combination with the vaccine, but you could talk about that if you want to.
Well, the question is just when will we get to a critical amount of immunity that we can behave more normally? And that's still a bit of an unknown because we don't know even if vaccinated, if we don't have enough people immune, we don't know if somebody who is vaccinated, even if they will be fine and won't contract illness from the infection, if they wouldn't be a carrier for a little while. If the virus got into their nasopharynx and so forth. So until we get through a certain amount, there's probably still going to be advocacy around masks and many of the other mitigation strategies. But I think everyone's pretty optimistic, and the combination of folks who have contracted COVID and recovered, but we don't know how long their durable immunity will be. We know that the durable immunity from a 2-series vaccine is very long. We just don't know how many months will it get us through this without ever having to be vaccinated again or not, what the booster schedule should be in the future. But a combination of enough of the population having had it and recovered, and enough of the population getting to a vaccine, we start to see real impact on the whole herd immunity thing, starting around 60% of immune, and radical differences to really getting to a place of being able to really eliminate the concern once you're getting up above the 75 to 80% immunity level. Which, so long as we can assure safety, is why people are encouraging vaccination. Here's the reason. Even with everything going on and the crazy statistics you've seen about COVID and the number of infections and deaths and so forth, that all has occurred with still a very minor segment. Even when we look at antibody levels and so forth, still fewer than 20% of the US population has been infected with this. So if you were to just let herd immunity go without a vaccine and let everyone get sick, the number of hospitalizations, deaths, illnesses that we would have to incur to get there is still pretty staggering, and that has the healthcare community going. That's why we couldn't endorse that as a strategy and needed to hold out until we could get the vaccine to be a component in that, so that somebody could get to immunity without the risk of hospitalization or death. That makes sense.
All right, thank you very much, Dr. Lewis. I appreciate you taking your time, and it has been informative. I think we've heard some applicable things that we can help with our discussion tonight. So thank you. I do appreciate it.
Thanks for having me.
Sure, thank you. All right, so we will move on to item number 4. This is discussion and possible action to approve or not approve a decision matrix to be used by the superintendent to determine when school will transition between in-person learning and distance learning or some other learning method, including student participation in extracurricular activities. So I think everybody should have a copy of decision matrix that I know Mr. Drummond and I think Ms. Packett worked on along with Mr. Eisenberger. So, Mr. Drummond, do you want to talk to us about this? Thank you for all of your work on this. It's beyond what I could come up with.
Members of the board and Mr. Superintendent, obviously, my name is Jim Drummond. I'm the assistant principal. I'm also the head baseball coach. And most important, the thing I want to say today is, after that stomping of Navy, how about that Army football season? I'm a 1983 graduate of the United States Military Academy, and listen, Saturday was a great day. Okay. I got a call or a text last Sunday that said, the Sunday before a week ago, would you be able to make a decision matrix that would aid the board in making a decision, or at least look at it to see how this matrix might be of use? And let me say first, the matrix is just intended to be a tool that hopefully you will be able to use to make the right decision. And the right decision is, when can we get our kids back in school as soon as possible? We all know that. But we want to do it safely. And so, we have different opinions on when to do that. The matrix is not intended to give you my opinion. It's intended to give you a framework that you can mold in a way so that it will fit the needs that you see. Okay, so there are two questions, and you'll notice for each grade there are 2 pages. So when I say grade, I mean high school, middle school, and elementary. So the first decision that must be made is, what criteria do we need to use in order to determine if we're in a virtual setting when we can go back to school? I mean, there has to be some sort of criteria. And so what I did was I attempted to make that criteria so that you could at least have a framework. And then if you didn't like the criteria, or if you wanted to adjust some of the data points, then I would have done my job, which was to give you initial framework. The second decision that must be made is, once we are back in school, if we are in something like an AD setting or at a 4-day setting at the elementary, when do we have to either consider going back to virtual, or when can we say, hey, we're doing so good, we need to get back to school full time? And the framework changes just a little bit, because there is some data that's available when we're in school that is not available when we're out of school. So let me talk about some of the items that I selected, and then let me talk about why I selected those items. Each one of the pages has 2 points, or 2 areas of concern. It's the community impact, and it's the school impact. Under this guise, if the community itself is having trouble, but the school is not, those are can be two mutually exclusive entities. If we're not having any problem, but the community is doing great, our community is having a problem, they don't necessarily have to go together. But the likelihood is we're going to be reflective of the area in which we live. So the first indicator that we used was to try to determine what exactly is the rate of transmission for 100K we started with the county. We looked at the county. The last 3 indicators, we couldn't get anywhere below 80, a value of 80. So the first, and then the last 3 months, or last 3 indicators and weeks, the last 3 in data provided by the state COVID map, all of the numbers were 80 or above. So the first question to say, are we using the right data? I mean, are we using data that really is indicative of our school district? So the data that was given to me was the top 7 zip codes. And unfortunately, when we evaluated the top 7 zip codes, it got worse, not better, which is indicative, and that was as of 12/8. The number went up to 149.3. It just means that we're in a tough stretch. The good news is it looks or appears to me that everybody goes through a tough stretch. Ours just happens to be now. But if you go up a hill, you're eventually going to come down. But anyway, the indicator was selected just to try to figure out the top 7, what is most likely to represent our student body. Okay, then there's the second indicator. The second indicator started out with ICU beds. And the first thing I looked at when I did ICU beds was I couldn't figure out what the heck the number was. And if you look at a lot of the collection points, they can't give you a number either because it's not something that's realistically tracked. And it means different things to different people. So just the same way we use the Oklahoma State School Board's designation of 50 and above as being a red area, I said there's got to be a state element or a state function data point that we could use, and that's the hospital surge plan. That's what Dr. Lewis was talking about. Now, the hospital surge plan has 4 tiers. There's tier 1, tier 2, tier 3, and tier 4. Tier 1 is less than 15%. When the thing came out on October 27th, it was 15%. There was nobody above that. The second tier is above 20%, and then it goes 20 to 39, and then it says above 40. Well, since we used an indicator with 5 different points, I took the 20 to 40 and broke it in half. 20 to 30 and 30 to 39, if that made any sense. Because there's a big difference between 22% and 37%. But according to the state, there's not. We needed more accurate data. So if you look, that's why I have those different designations. Now, this is the state's tier plan. And they use green, yellow, orange, and red. And we have consistently been, unfortunately, since the 26th of November, we've been above 30, with one exception, December 6th.
When you say we, is that the state or?
That is Region 8, Oklahoma City. So, once again, I use the local area, sir, as opposed to doing the state. Because it's true, Tishomingo has nothing to do with Bethany right now. And so, that data, what I felt was not really applicable. All right, so those are things that we can look at that is from a community aspect. And unfortunately, right now, it just so happens to be that it's not real good. But that doesn't mean that necessarily that's what we have to do because we have to look at our school. So here's what I think you need to look at for a school when you're in a virtual setting trying to decide whether we can have school. And that indicator is, what's our operational readiness? Can we host school? If we can host school, it's totally dependent on, can we get teachers to staff it? I mean, that's whether determines whether we can host school. Okay, so what are the things that keep us from having school, having a teacher present? Well, a teacher's quarantined or a teacher's COVID positive. And if I have a teacher in that capacity, what are the number of people that can fill that role? The number of subs and support staff. Well, each school is going to be different. The middle school is going to have a different number of people available than the elementary. And the situations aren't quite the same. But for the high school, which is what I can speak to most often, our sub-availability has been real good. But that doesn't mean that we can't send someone who is not normally a teacher to teach a class. Many classes this year. I've taught math at least 4 or 5 times, and I've gone to other classes. And in fact, it's kind of nice to get out and teach class and be with the kids again. I've enjoyed it very much. But really what we're doing is we're measuring the number of people that are out versus the number of people we can put in their place. Because that's the only thing I can do. If you said, let's go to school tomorrow, I could call all my teachers and I could say, are you going to be there? Are you okay? Are you quarantined? So I could get a number and I can tell you whether or not we're going to have classrooms unmanned or whether we're going to be able to man them. So that's what I looked at, operational readiness. What the state looks like, community, what the school looks like for teachers available. Now, in the decision matrix, you have a column that you select, and you just simply add up the numbers. And you'll notice on the third page is a graph. It's really a grid. It's a grid in which you cross-reference community, which is the horizontal axis, and the vertical axis is the school. So you just cross-reference the score, and then you find the total points. So if you've got a 1 for a community and a 3 for a school, then you get 4 points. So you're going to get a score from 0 to 16. Now the indicator is such that you're going to, in that case, you're going to get a red, a yellow, or a green. Green means you go to school full time. Yellow means that you're in 4 days a week for elementary, or you're in AB schedule for high school and middle school. And red means we need to go virtual. Now, here's what's great about a decision matrix. If you determine that the matrix isn't set at the right set point, you just move it. And it's really pretty simple. You make the matrix work for you. Like for instance, all I did was take the same matrix and I wanted to change the impact on the school such that the school is more important than the community. So all I did was I moved the line 1 over. So what that ensures is if the community is really poor, but the school is doing great, I just move it over and it's not going to affect it. So if you think that the data is too much to the community, just slide it over. You make the matrix work for you. All right. So then there's the next matrix. The next matrix is the one that is used when you are back in school. All right. So let's say the decision was made that we're going back in school. Pick a date, we're back in school. Now, data changes. The data that I did not have before was student data. I don't know how many students are quarantined or how many students are positive, unless they happen to call me beforehand when they were home virtual. But really, there's no need to call me and tell me you're quarantined with virtual, because you're able to do your work. You might want to do that, just in case your teacher would know. But usually, we do not know the data as far as the effect on the student population until they get into school. So what it attempts to do is determine, in this matrix, it uses the same data for the community impact, but now the emphasis is basically shifted to the top layer of school impact. It really measures the difference between the number of teachers you have out and the number of teachers you can, or people you can put in the teacher's place. So here's the thing, the high school, if you had an unmanned classroom, that was really easy. You just put it in with another class. And you were able to work that in some manner. You could work together with another teacher, and the teacher could handle. In an area of this size, because we're one-to-one Chromebook, a teacher could say, hey, are you working on your assignment? Your teacher gave you an assignment. They told you what to do. Here's what it is. Are you working on it? I got it, coach. It's in the Chromebook. I know what to do. So you could monitor an extra class. But now because of social distancing, it gets a little bit more difficult. We can still do it. It just gives you an idea of operational effectiveness once they're in the school. So this was to determine when you can go up and when you can go down. Now, the real test of this matrix would be, does it pass the test for decisions we've already made? And so, let's just take the decision that was made, the toughest one we've had to make in a long time. The one we're not sure what we should have done, we don't all agree upon. Let's take the most recent one, the one that was made on 11/30. The one that said, I think we're going to go virtual. Well, if you look at that matrix, first of all, at the top, the community impact, you have to look at where you're at. You're in school. Well, that was tough because we had a 10-day absence. We were in school, but we really weren't in school. But by using the matrix says we have to look at it as we're A/B, determine whether we go virtual, or A/B, whether we're going to go in-person learning 5 days a week. Okay, so here we are in school. So the first thing we do is we look at the community impact. Well, the community impact at the top is not very good. It's no secret that the COVID rates have been above 50, which is the state school board designator for red, for a long time. Okay, we can debate whatever or not if that number, I don't know where they got the number 50. Probably because it's a number that you can physically understand, 50. But according to the state, that was a red flag. Okay, so the next thing is what are our rates for the second indicator? Let me look and see what I have to look. The second indicator, what were our rates for the hospital surge plan, the tier? So the tier is tier 3. It's actually 3B is what we are. We're at 33%. So tier 3B would mean we got 1 point. So we got 0 points for the transmission rate, whether we looked at 7 zip codes or whether we looked at through the entire county. Either way, we got 0 points. So we would have got 1 point for our community impact. Now, let me speak to the high school, because I can't speak for the elementary, and I can't speak for the middle school. So now we're going to look at the number of teachers I had available versus support staff. Well, let me tell you, we had 6 teachers that were out that week. We would have had, at best, 2, maybe 1 person that could have done it. I mean, we could have put people in there temporary, but we could not have put in anyone full-time for the entire week. So the score for that is not going to be very good. In fact, the score is going to be, using the chart that we have, it's on the second page. The score that we had would have been either 1 point or 0 points. It would have been problematic with 4, or it would have been alarming with 5. Because 6 minus 2 is 4, 6 minus 1 is 5. And that's where we would have been. We would have had a deficiency of 5 or deficiency of 4. Now, we came off of a 10-day break. Off of a 10-day break, we had 6 students that self-reported. I don't know if that's right. Maybe every kid in the district did exactly what we wish they would have done and would have told us. If we would have had all 6, then we would have had all 4 points on the student scale. It's also true that we probably had somewhere closer to 25 or 26. But the question is, what should we have done? Well, here's the thing. At best, that is 1 point in the community and 5 points in the school. At worst, it's 1 and 3. Guess what? That's right on the cut line. So what it says was, boy, you've got a pretty hard decision to make. So it's right on the cut line between the red and the yellow. Does anyone here not doubt that that was an unbelievably hard decision to make and that there are people on both sides? So here's the thing. It is a tough decision. This matrix follows it. And if you follow the matrix today, it would be a 1-6, which would say, see you in school tomorrow morning. But now, the only reason it's a 1-6 is because I don't have 6 teachers out anymore. 6 would be the total from the school impact. I don't have 6 teachers. I could get a full 4 points, or I could get at least 3, because I have 2 that not feeling well right now. So, what I'm saying is, you can mold this any way you want to. You can make it work, but it'll tell you when to go back, and it'll make sense of when to go back. The hard part is just figuring out what to do at the beginning of January. Because none of us know what's going to happen. Do we come back after Christmas? Do we get after it? Are we careful? I mean, all you have to do is just turn the channel, and someone will tell you something different. I'm not telling you anything you don't already know, that you have a very difficult decision to make. But if you'll use this matrix and mold it so that it gives some clarity to what it is you want to measure, and we've even adapted it just a little bit this evening, how we can make it a little finer, what the proper number is for the elementary school. Then the good thing about it is you don't even have to use the same cut lines for your schools. Because I think we all recognize that the rate of transmission is probably a little bit different in the elementary school than it is in the high school. And the need for a 7-year-old to not be in front of a computer is probably far more important than it is for a 15-year-old. And a 15-year-old can sit at home and supervise himself, whereas a 7-year-old needs a 15-year-old to watch him when mom's at work. So, look, I hope that I can use this matrix, or you can use this matrix to do with it whatever you want. But the matrix itself, other school districts have used it, have helped in the decision-making process. I want the same thing everyone else does. Once again, I want our kids back in school full-time. I can't practice baseball if they're not here, but I don't want anybody unsafely practicing baseball here. And you know, a day without baseball to me is a pretty tough day. And so everybody's hurting. And if I can help you, I'll redesign that in any way. I'll change the indicators. I'll move the lines. I'll do whatever it is you need to do. I want to help you because I recognize what a tough decision you have to make. And thank goodness somebody's willing to step up and make the decision. You know, thank goodness somebody is willing to step up and make the decision. Because everybody will tell you what you should be doing. But when it comes time to say, okay, what should we do? Okay, I don't know. If I can help you anymore, I would be glad to.
Coach Jarman, first of all, thank you so much for all of your efforts with this, as well as, I think you said, this packet associated with it. Thanks for your help with that.
Agreed, yeah.
Might turn that off.
Yeah, me too.
Go ahead, you have a question. How about it?
The question I would have is, can you speak a little bit to, so there were 7 zip codes, 73008 being the lion's share of those students. So there were 6 other zip codes that were used primarily, correct?
Yes, sir.
Okay, and with those, were those zip codes weighted based on number of students from those zip codes? Or can you speak to a little bit how you came up with that figure?
Yes, sir. All right, I used a weighted average. There are 1,692 students in our 7 zip codes. The top zip code, 73008, has 1,007. 1,007 divided by 1,692 is 59.5%. So 59.5% is what I multiplied by the current rate for that zip code. All right, let me give you by zip code what the rates are. Our top 73008 is 144.8. Our next 73099, where I live, is 257 students, is 208.7. 73132, 159 students, 128.6. 73162, 108 students, 133.29. 73122, 64 students, 131.67. 73112, 54 students, 102.34. 73127, 43 students, 116.29. So what I did was I just did the average. There's 59%, 15, 9, 6, 4, 3, and 2.5. And then I just weighted it, and the number came out to be 149.5.
Jim, just to clarify, that information did come ultimately from the State Department of Health. So that is a good source, I would say.
The zip code information?
Yes. It's easiest to access it through the.
But here's the good thing. The good thing is look, those numbers are not good. I mean, if the number 50 is statistically relevant, those numbers are terrible. They're not good, they're terrible. But here's the positive news, okay? The positive news, if you look at the chart, just because the community rate is high, we can still, at this time, the next number was the surge plan tier. The surge plan tier gave you a number of 1, which is not good either, but it gave you a number of 1. And if you look at your graph or with your grid, with a number of 1, you can still have school. But you can only have school if the school impact is small. And small being, you need 5 points. And 5 points meant you have enough people to cover. So as long as your teachers were okay, then we can still have school. We might not have school as long as we'd like to, according to the grid, but we could have had school. But the problem was when we came out of Thanksgiving, I had 6 teachers that were out in that week. And that would have made it tough.
And those 6 teachers all tested positive, is that correct?
No, some were quarantined. And so the good news is if I get a teacher that's quarantined, they can still produce work. The bad news is someone has to sit there in that class and make sure that they're not doing the other things that get kids in trouble. So that's why we do support staff, but it's not ideal. Does that make sense?
And those teachers were quarantined due to contact tracing from our contact at the health department, or they just stated that they had been exposed?
It's the state determines
Yeah,
yeah.
I don't quarantine anyone, sir. I mean, I can't, Mr. Melton can't either. Those are all what we got through the State Department. But look, we could have, it was real close, but we still could have had school. But now here's the decision. Could we have had school for very long? Well, that was a tough one because as indicated by the grid, you were right on that cut point. And the question was, were we really at 5 or were we at 4? And the reason that made it so tough was we were in school trying to determine whether to stay in school or go back. And we did not have the data that we really needed. The most important data was we needed the data from the students, and we didn't have that available. And the reason we didn't have it available is because even though we were in school, we came back off of a 10-day break, which in essence meant we were really virtual. So, I mean, look, it was a horrible decision to have to be made either way. And I don't mean like the decision was made was bad. I meant was you could not win in that decision. I mean, because there wasn't enough data on one side to make it definitive either way. And so you had to go by intuition. And the only intuition that you could go by was what you got from other people telling you what to do. And where could you get that? You could read, you could listen to television, you could listen to the radio. And we know that, gosh, I mean, you have so much information. It is so difficult to determine, especially when you have to make your information or your data is not really full. So either way, it would have been a bad decision for half the people.
So I have a question for the principals real quick. How, after last week's meeting, has your sub availability increased? Have you had enough people submit applications to be substitute teachers?
I have not heard anything from Carolyn, no, so I think we're kind of in the same situation, a challenge of some availability.
What about guys, elementary and middle school?
I think we're probably in the best shape overall with subs. And we also have more support staff that can help if needed. It's not preferable, but can. So I think we're probably in the best shape as far as subs go.
And then I have a little bit better than Mark, but not as much as Mr. Bellows. And then we also have of coming up, so I just know of a couple, and then the Wimross, obviously, and I did not check what level, but I will make sure he is middle school as well. And that's what, when we started talking about the matrix, we tried to incorporate what we could do based on how many people he has available with aides, and then same with me, because we use those people as subs sometimes as well. And so that's in some of these numbers. That's why the numbers are there.
And I think it's important to think about too, because sometimes we'll have an anomaly where even, in a regular year in the spring, you might have 5 or 6 teachers that are out sick with flu, etc. But, with this, we're talking about a minimum of 7 days. If it's a quarantine or positive, it could be 10 days. So that's the interesting part.
So are we at a point to talk through the criteria, the question that Mr. Drummond
Yes.
asked, which
Yes.
is the criteria correct? So
Yes.
I guess the question I have rattling around in my head is the hospital surge plan number. I'm glad to see we pivoted from looking at an absolute ICU bed number, but I question maybe the inclusion of that in this. Would the community number be enough? Like the top 7 student zip codes.
Don't know that I understand the question.
Well, so I guess I'm questioning having that included in our community impact score.
So you're thinking just
Throw it out.
strictly look at the zip code information and not.
Yeah, and I guess where that's coming from is through the conversation and the reading that I've done with the transmission numbers being low, at least in the elementary, and it kind of gearing up as the age goes up, and just wondering if in a school, and it's kind of what Dr. Lewis was talking about, if in a school setting, I don't know if there's a statistical correlation between the surge plan and us being, everybody wants to do what they can, to help improve the pressure on healthcare.
But maybe it should be in the high school because they're more likely to transmit, not in the elementary where the transmission rates are low.
Yeah, I just wanted to kind of debate that number on the community impact level.
Well, because it's equally weighted, right? I mean, it's as much of a piece of it as everything else. It's like equally weighted. Well, and I think this is the thing I have felt through this. It feels like this is kind of out of my purview to be determining hospital beds in Oklahoma County when I'm making a decision for kids. Does that make sense? Like, it feels kind of.
We're in the education business.
Right, I'm like, I'm in the education business, kids are our number 1 client. And it's like, it feels.
But if those hospital beds affect our staff, it does affect the kids. So,
But is it weighted as heavily? Is it weighted as heavily? I mean, right now it's equal.
Do I like it?
It's kind of equal, and this, it's equal.
Yeah, I agree.
But to Courtney's point, then, if we dial down the sites, recognizing that it's not the same transmission in
Right.
elementary, and we pull that piece out of the matrix, but consider it secondary?
Yeah,
That we're thinking?
to me, that makes sense because if the transmission isn't as great, the likelihood to pass to staff and other family members is much lower there than whenever you get up to high school level. Now, middle school, of course, is in between. I don't.
Yeah, that's something to think about. They're kind of in the gray area, and you have more, you've got less teachers, smaller, it's.
Small
Yeah.
size.
That's something to think about.
I guess I would just advocate for maybe pulling that number from at least elementary school. Just based on what the physician shared tonight and the pediatrician that I spoke with, and just kind of that transmission rate, the studies that have shown. I guess that would at least advocate for maybe pulling that from our elementary.
Okay, that
I think you can definitely make a case for that.
So I have a whole list of questions, and I'm happy to just walk through them unless somebody else has a follow-up.
Go for it, Cory.
Okay, so, and I don't want to assume, but I'm assuming that the intention is to maintain this matrix each week on a regular cadence, and that all 6 of these would be completed on a regular basis?
Depending on what we're in.
Okay.
So 3 of them would be completed each week.
Okay.
High school, elementary, middle school. The principals will complete those, send them to me, and then we'll put that out to the public.
Okay. So, Dr. Lewis's conversation about trends is interesting to me, and when we started, the intention was to use the map and to give that a couple of weeks, knowing that there's kind of a lag in numbers. And so I guess my question as I look at this is, and this kind of gets to the other question I had about a concern about the whiplash effect. So, how do you weigh consistency versus immediate action on something in preparation for parents who may need to make, or will have to make accommodations? And so, how do you account for the trends? How do you, to what Dr. Lewis was talking about, kind of looking forward? Is this a like each week that decision gets made for the next week, or I'm just curious about how you implement it, actually start using it.
I think we did have, previously, we had a 2-week, we've said that the map had to be at a certain point for 2 weeks before we would make any changes. But I do think that whatever we decide on, there needs to be the flexibility. If something tanks, we can't wait 2 weeks. We're gonna have to say, okay, we can't go back to school on Monday, or we are going to go back, or, whatever.
And the opposite holds true. The
Exactly.
numbers, or the score indicates,
Right, there may be,
Right.
15 middle school students that test positive over a weekend or whatever, and that could make a huge impact. Versus, we could have a ton of kids come out of quarantine and not be positive anymore, and so that could make a big difference. So with that, I don't think we need to wait 2 weeks for a change. Does that make sense?
Yeah, how do you, I think whiplash is a perfect word for it. What are you saying, Les?
I don't
He's
know how
falling over
you
the
account
trend
for
question.
the trend,
Yeah,
unless you go to some percentages or a rolling average of 2 weeks or something like that. And you're always gonna have the chance that a large number combination of positive and quarantines puts a big dent in whichever, any of the three. It makes it almost impossible to have school. If you have that, huge number of staff go, you just don't have the replacements for it. You just can't have school. And we have to account for that.
Well, I think we can make the best plans possible, but I think we're still going to have to maintain flexibility, because obviously none of us have done this before, and so I think we just need to keep that in mind. Let's just do the best we can, come up with the best plan that we can, and know that something may happen. Who knows? It may just turn out to be wonderful, or we may have to jump back and do something we don't want to do, but we may not have an option, so.
That was, well, that was a lot of my questions.
well, we're already in the least desirable place to be, right now. So, what did you say? I said we're already in the least desirable place to be. Full virtual is obviously not what anybody wants, so we're already kind of there. So, you're right, we've got to be flexible. But this is a better tool than what we were using before.
I think this is
It's a
basically,
better tool.
yeah, it's the same, it is a better tool. It's a lot more detailed than what we had. It's basically the same thing, but we have just increased the data that we're looking at. And
make it a lot more.
Well, and as he said, there's more data now available. They're making more things. We have more data points and we have better reliable information. So therefore, we're gonna have a better decision.
Okay, so what other questions do y'all have? We want to think about pulling out the hospitals for elementary.
Yeah, definitely.
What would be the timing of when we fill these out?
So again, was
Timing of when we would fill these out and notify the public?
we can do them anytime. We can do them, I think most of the data that we get is updated daily. Is that true, Jim? You know that?
I'm sorry,
The data that you got, like on the zip codes, is that updated daily or?
The data I got was from 12A. So I don't know how often they publish the data. That was the data that was provided me for one day at a time, 12A. I don't know if they publish it weekly, daily, or I have to defer to that question.
Okay, so we don't know for sure how quickly we get the data, how often, but, I would think a Thursday or Friday, so that we can deliver it to parents on a Thursday or Friday, so that they have that much time. And if parents or you guys think we need to do it on Wednesday for the following Monday, let's do that. I just don't know when, I don't know what our, what data, how up to date that data will be on that day, but we need to pick a date.
I think that the data from the state is typically updated on like Thursday, Friday, like the zip code information, I believe is daily, but typically they come out on a Friday, Thursday afternoon, Friday.
That map from OSSBA comes out on Fridays, but I believe the zip code data is done daily whenever I've done county. It's like on there every single day, I believe.
So the question remains, when do you want it done? You tell us, we'll do it.
I would think Thursday, gives you Friday, if you're in school, gives you Friday to prepare everybody going for Monday, I would think. Now, Wednesday may be better, maybe it gives you 2 days. But then, but once you kind of get consistent, then everybody knows when it's gonna be. You can get your plan in place to how to notify, how you get ready to make the transition going into the direction.
Just
Yeah,
on
this
Thursday.
first spot is
Yeah.
Thursday, but
If it doesn't work out, or we get feedback that need more time.
I think Friday's too late.
I'm fine either way. I don't know how a strong opinion about that. Just trying to think, it seems like, I don't have a strong opinion about that. Just as long as we pick a day and we're consistent with that.
Okay. Do y'all have any other changes or questions about the decision matrix? Is there anything you'd like to see or not like to see?
I don't know, guys, I'm gonna take a little time to absorb it. Since this is the first time we've seen all of these pieces together, is anybody else feeling that? I need a little time to absorb. I don't know if I can right in this minute.
It's a lot.
It's a whole lot too. Yeah, if we really wanted to take a vote right now, I would be prepared. I'll just be straight up. So I want a little time to absorb it, but I think it looks great. It makes sense. Let's use data. I love drilling down into the zip codes. I think that's really good. It's interesting. I can't believe I'm saying something. I know so many of our students actually live in 736. So I was like, wow, okay, this is good. But what else? Courtney, you said you had a question.
Well, you guys have kind of, I think, addressed it. It's just that it's the question of consistency versus, being flexible. And
Yeah.
it's uncomfortable, especially for me who's a type A planner.
Well,
you know,
but
it is real-time data, so.
It's out of consideration for our families though. I mean, that's the thing. We have to be considerate of their schedules and how, you know, all those things fit for them as well. So I thought that was a great point.
I'm with Heather, like a little, I mean, I agree, I think we have to probably, time is of the essence, but I also feel like I need to process just a bit.
No, I agree. I would like to, probably like to look over, this is the information that I'm thankful to have this information. This is the, kind of the text on that Saturday night that you and I had, that I said, hey, let's talk about this stuff. So let's see what we've got. And so that's something that is very valuable information, as I mentioned, for Sterling.
I think it makes it obvious that the decisions that are made are based on fact, and it's not just throwing darts against the wall. So, and I think it'll be good to show our families that as well, that we're looking at the facts.
Yeah, good data. So,
All right, so we'll just wait. Or do y'all feel comfortable with looking at this, thinking on it, seeing if there's anything?
We take no action.
yeah, all right.
Well, I do want to say, Mr. Drummond, thank you. I could not even begin to wrap my head around putting together something like this, and I know it took you a lot longer than 30 minutes or whatever. It took a lot of time, so thank you very much. That's much appreciated. Okay, let's look at then item number 5, discussion and possible action to approve or not approve determination of the student instructional schedule, which may include distance learning, in-person learning, or some other methodology by the Board of Education.
Let me tell you what that means.
Yeah.
It's a lawyerese that means this. If you vote yes on this, if you guys choose this, then you will choose every time. We have to meet before we can go in or out or change the instructional cycle whatsoever. So we have to meet on whenever to go into distance learning or go out of distance learning, go into whatever. Where it gets really complex is that if we use the decision matrix that we just chose, we're going to do that for every school. So it could easily be that the elementary stays the same, the middle school and high school do something different. We have to meet, if we do this, this is just giving you the option for the board to decide every time we change.
Per side.
So let's talk about
Yes,
that.
absolutely.
Right.
Yeah,
So-
so the implication being that if we're updating this weekly, we could be seeing each other each week.
Yes,
Would
either
you like me, Courtney?
if we want to meet and do that, to say, okay, here's the decision matrix, this is what we're going to do. Or do we want to say, and I think this is right, we want to say, Drew, you've got the decision matrix, you can make that call, we don't need to meet.
Yes.
So that's what we're looking at.
Like we did before, you gave me, wasn't a decision matrix, it was just a thing that you told me to use.
It's a tool.
And that's what I use. And so if we do nothing, that's what we'll do. If you don't take action on this item, we'll continue by using what we talked about. You guys haven't voted on that decision matrix yet. You don't have to. All you gotta do is tell me to use it, and I'll use it. It's the same, has the same weight as voting on it. Gives you a little bit of time to look at it, and then ask questions. We get them to Jim. We changed it up. On the 4th, we have January 4th, there's another board meeting. If you want to officially adopt it, you can. We can have, with 48 hours notice, we can have a board meeting anytime, week or weekend, during the Christmas break. So, just gotta have 48 hours that are during the week. Still be on Saturday.
So that begs the question, so if we are updating the matrix on Thursdays, then would we, I mean, if you had to post the board meeting 40 hours in advance, you would just have to have that at the standing every Thursday meeting,
That's correct.
regardless of whether we're taking action or not. Or,
Yeah,
or
you
we
can
can
always
take
do-
action every meeting, every week.
That's right.
Okay.
Yeah, so what do y'all think? Do you want to basically schedule a meeting every week to look at what we're going to do and vote based on the decision matrix? Or do we want to continue to give Drew the authority to do that?
I mean, it's,
I personally, I just prefer doing it the way we're doing it, with better data, or better tools for us to use and for us to know where we're headed by having the same tools in our hands. That's my
I mean, that kind of just, it nullifies the point of the matrix if we're gonna meet every week and decide. I mean, that's the whole point of the matrix. And to Melissa's point, it's the data. And if it's data driven, I think that's good.
Yeah, I guess that's I guess that's where I go as well in terms of, the idea was in creating a better tool, a better decision maker, so that we could feel more confident that we were using data and we had something that was a little more of its time. I mean, I think we've just evolved since August.
Well, and obviously, once we have time to absorb it and go over it, we may come up with something else too that we might need to tweak, refine, or whatever. But yeah, that's the whole point of the matrix.
Kent, what do you think?
Yeah, I mean, I agree that that's the point of the matrix. However, I will tell you, I mean, it's important to our community, and if I need to be here weekly for a vote, then I'll be here weekly for a vote. I ain't going anywhere, I haven't gone anywhere since March. And so I'll be around.
It's the same. I'm just trying to understand the institution behind it. I think I'm not going anywhere.
So you want to do a weekly meeting?
I mean, you can always cancel a weekly meeting. Right?
Yeah.
You know, what we don't know, I can say that we don't know what's gonna come down the pike as we get into the spring. There may be other things we need to speak about, so we have, I mean, we can always put a meeting on the calendar too, I suppose.
Yeah.
Something were to pop up.
Well, I mean, to his point, he's saying through January, it looks like it's gonna be kind of more probably more up in the air, and then maybe going down, so maybe through January, we meet weekly, and maybe, I mean, we can always change, we don't have to. We change our minds.
By him, you mean Dr. Lewis.
Yes,
Right,
sorry, yeah.
so-
Yes, but to your
so-
point, the crystal ball, what do you see? I mean, it feels like January will still continue to be a rise in cases, but then vaccinations will catch up and have some kind of impact on. I mean, did you interpret that? Maybe I should have confirmed that with him. I felt like what he was saying was
That with vaccinating his hospital staff, one of their issues right now is their people are getting sick as well, and so they don't have enough staff. Is that how you took that? So if they're vaccinated and not getting sick, then they have staff. Is that how you all interpreted that?
They're starting out with the hospital staff, like the front.
Correct, but that's been one of their, sounds like that's maybe been, which is why they're doing that, because they want to keep their staff well so they can treat patients.
Well, I think, so what I thought I heard him say, and again, I may have misinterpreted, but was that he was optimistic come February, once there's a higher percentage of the population that had.
Either contrasted it?
Will take the vaccine, that would level off, yeah. But
Oh, okay.
again, it's crystal ball.
I mean, yeah, I feel like he has a pulse.
Right.
But that may be something I might want to
verify with him, like, I mean, I'm just assuming,
But the point made though is a good one, Ken, that we can proceed with approval for the board to meet and make this decision on a weekly basis, and if at some point we feel that we have that we feel things are operating, we don't need to do it, we can always do another road.
okay.
So it sounds like we're leaning towards possibly you wanting to go with taking a vote initially. And then that. No. I'm with you, Les. I feel like if we decide on this decision matrix, I don't know, I don't see the point.
Yeah, I mean, if we vote to agree on the matrix, I feel like that's a vote to agree to do the matrix. So again, like that's boundaries, but that's kind of an agreement that would be the decision-making tool, and that would kind of drive those decisions forward, right? So, I mean, that's where I'm struggling with it a little bit.
When would be the first time we're meeting?
Well, and so I think that's what I was saying, is I feel like time is of the essence in getting the matrix where the decision matrix where it needs to be, so that we can start using it. So I'm not opposed to coming back together, you know,
Prior to
maybe
January
address
fourth.
it.
Yeah.
I feel like, I mean, you know, next week, early.
I don't know that a vote on this is required right now.
On item 5.
Fine.
Yes. Until we determine.
Or 6.
Yeah.
So, as you're saying, that you think we need to return to number 4.
Let's determine the matrix, and then we decide whether or not we feel like that, you know, we should either want to confirm the matrix or administration just uses it.
So it's another no vote on 5.
Yeah. Yeah. Courtney, you wanna nail down the matrix prior to our next board meeting?
Yes.
Yeah,
I mean, yeah, absolutely. I feel like it needs to be, that's just, I feel a sense of urgency on it, and so I feel like we owe it to the.
What are we doing,
administration.
Thursday, right?
Yeah, I mean, so.
Okay, yeah, good.
Okay, so,
Yes. Does the matrix, I assume you're moving to 6 now? Sorry.
Yes.
Take a vote.
If you guys want to wait, then let's.
I guess the question is, does this drive number 6 as well? Or is 6 a whole different discussion?
So, right, so number 6, is discussion and possible action to approve or not to approve a rule for which students may participate in extracurricular activities in light of the COVID-19 pandemic status established by the Board of Education. So it sounds like we are going to think about and decide on the decision matrix, which then will drive what we do on number 5. So we want to meet later. Go ahead, Les.
I'm taking the reason this is on here is that we're trying to decide if the students are in virtual, so should or should they not be in extracurricular? Right? I mean, it's not written there, but
That's
the only thing I can
That's correct.
is, you know, infer from it is that because we're perfectly virtual and the students are participating in extracurricular. So I guess I was assuming this is asking, are we going to stick with that rule, or is there a time when the matrix points to that those don't occur?
Well, yeah, that's a great point, if that's not included on the matrix, and that was a good catch. It
I mean-
should that be part of our matrix?
Well, you could also just tie it to, if there's no decision made on the matrix tonight, could also just say, you know, if you proceed to virtual learning, then this happens. So,
Which is part of the matrix, or, oh, that's just, yeah.
it doesn't necessarily have to say we've determined what the matrix is, but when it is determined, then we do go to, you know, virtual learning. This is the rule on extracurricular activities, whether it's to keep or to cancel. I mean, I don't know that you have to have a decision on the floor to have a decision here.
Right.
I mean,
Well, the only thing is, unlike school that ends Friday, I'm assuming over Christmas break, we will have extracurriculars occurring and/or practices. Is that right?
That's right.
So, I don't know opinions, we haven't had these discussions, so I don't know if people were looking to that decision for Christmas break, but we from that.
Or are we looking at that as something when we, for next
Set up the
semester?
matrix.
Yeah.
Yeah, that was my question, I'm just throwing the question out there.
I'm sorry, did you say for next semester, Angela? Yeah. So just continue in the mode, I mean, what we're doing now? Continue with extracurriculars, but we're virtual.
So,
It seems that the extracurriculars probably ought to be tied to the matrix, shouldn't it?
that's up to us. I don't know, other schools, Chris, can you speak to,
Some are.
how do other
these-
places do it?
BC is doing virtual, but they're limited attendance like we are. We're at 10% attendance. The rule that that's talking about is that document that John gave you guys last week, the red, green, and yellow. You don't have to use it. That's what this is talking about. So UConn has, when I talked to Jason Semiroff, he said limited. So they're only doing varsity. They're not doing JV. They're not doing any choir, orchestra, any of those kind of things. Piedmont is virtual this week, but they're still doing athletics. So,
Well, and is that possibly because the learning model or method can change? Well, I don't know, I guess that's what, trying to pull people back into sports or whatever on a weekly basis in and out with scheduling and so forth versus, I don't know, if that's a factor.
you know, for me, I need a direction from the board to say, yeah, we're going to do extracurricular when we're in virtual, or no, we're not. I can make it happen either way. If you guys vote to stop virtual or extracurriculars tonight, I can have them stopped in the morning. We won't have anything on Tuesday or Wednesday or any other days. So it matters not to me, but I need a direction. I've made, I gave you my recommendation. I told you what I thought and why, and we've been doing that. But I feel like I just want us all to be on the same page. I think that's fair.
So, I don't want to put words in. I think all I was hearing is do what we're doing until decide on the matrix and everything in January. So that doing what we're doing is doing what John gave us last week, right?
Correct.
So would you like us to vote, continue to do what we're doing on extracurriculars until we finish all this?
That's correct. That'd be great.
So I'll make a motion. Go ahead.
No, that's fine. I mean,
Most extracurriculars, though, are going to end by this Friday. Well, I guess is basketball going to keep practicing all the week of
Yes.
Christmas and the week after Christmas? Or
Yeah.
is that the
We'll have a
only,
little bit of time off, but they'll practice through Christmas break.
any other sports?
Soccer.
I see that hand, Mr. Drummond. Oh, Mr. Drummond, I did have one other question for you off that topic. What schools are using this matrix or using a matrix of this type?
Well, which school did I get it from, ma'am?
Yes.
There was a school from Aurora that I saw that there's two schools, one was Aurora, but it's a little different. I kind of designed, just basically, I took a hybrid of two different ones and made that.
But are any of the other metro schools using this matrix? That's
Or any other metro?
yes.
I don't know, ma'am. I couldn't answer that.
Okay, that's fine. I was going to ask you that question anyway, and then okay, so we'll have basketball and baseball that are going to continue. And we're supposed to start back, I mean, on the schedule, we're supposed to be back in school on January 4th, correct?
So let's define extracurricular activities. So that is not just sports.
No.
That is going, so it's not just your, like your outdoor, like being able to practice outside or distance in a weight room. We're also talking, extracurricular encompasses orchestra, choir, all school musical. So I want to be sure we've got the right scope here when we talk about extracurricular activities. And it may make me very unpopular, but I'm just gonna say it. I guess I don't understand the rationale of saying kids can't be in school to learn and continuing to bring kids into an environment where they may be crowded or in choir singing, which we know to be a risky activity. Unfortunately, as much as I love a good choir, I mean, it's known to be risky. And that was, I asked the pediatrician I talked to today, I said, what do you think? As we talked, and he was like, well, that might upset parents, but the reality is if you feel it's not safe to have kids in a classroom, because it's not just attendance at an event, it's all of the work that these kids put in, practicing day in and day out in environments, and not outdoor environments, indoor. So, that's just my opinion.
Well, to your point about consistency, and it seems inconsistent to say you can't learn in school, but you can play sports and you can sing and you can do these other things. And it's like, again, our number one job is to educate. That's what we're in the business of. And so, listen.
Believe me, I don't like I don't like where that takes you. I think we can all agree that the starting point is we want everything as back to normal as possible. But I don't know, if you're gonna take that step, I feel like it has to be questioned.
Well, I've maintained all along that mental health is really important, that we put so much emphasis on the health issue and there has not been equal weight played or given to the mental health and to, Drew, you said, the kids need to be, having their extracurricular activities. It's so important, but it's all important. That's the problem.
Well, and
That's the problem.
going off of what the research that I did, but also what Dr. Lewis shared tonight, and that those older as they get older, those populations become they're at risk for having not just mild symptoms, but I think you all heard the anomaly stories about some high school students across the state struggling, but they also become more likely to spread. And so when you think about extracurricular activities, where does that take place? It tends to pick up middle school and definitely in high school. So, and I don't know that it needs to be to Drew's point, it may not need to be an absolute decision. I don't want to make this more complicated, but do you look at varsity versus JV? I don't know. But I just think that the groups that are at higher risk for transmitting are the ones who are participating in extracurricular activities, and so the risk is there.
Well, and that, to Dr. Lewis's point, we're having them take all the precautions that they are taking. As Mr. Arthur shared this last week, we are mitigating, but we can't promise this is a completely risk-free environment.
Absolutely.
I mean, there is no way to be completely risk-free, so, it's just, it's hard. It's really, really hard to balance it all. But, I mean, the mental health aspect, I mean, there's a student that committed suicide in Maine, did you all hear this? The high school football player committed suicide. The 6th grader that committed suicide on a Zoom call in California. This is what I'm really concerned about as we keep going further and farther in, because we're 9 months in. At this point, really, if we can into it. And so I would like to see us, I guess what I'm saying is I think we should just go ahead and finish out, this is my feeling, we should go ahead and finish out the semester, let the extracurriculars go on, and we've got to make up our minds about what we're going to do in January and beyond. That's my feeling for right now. Anybody else?
My feelings would be that we're going to get back together to talk about this matrix. Now, when that's going to be, I don't know. I mean,
Sooner rather than later.
as early as Thursday or Friday, we could do that. And at that point, maybe we've all had an opportunity to think about what Courtney has said and what has been shared about the extracurriculars, what that looks like. I know we'll hear from some people for sure. That's one thing I do know. And so it'll give us that opportunity to make that decision with the matrix decision. What are your thoughts on that?
I mean, it's complex. I've said this before, this is the biggest decision, since I've been on the school board probably in 11 years, this has really been the big decision.
But it's not permanent, and thankfully, thank the Lord, it's not permanent. And this is just a temporary situation that we're in, and hopefully, we are going to be on the upswing, and so we're looking at just a week, basically a week basis. So I think it's helpful to remember that
Yes.
the decisions that we're making are not from now on. It is
Yeah.
for a given point in time, so.
So we have to.
All right, so I guess we don't have any action that we want to take yet.
I think we have to vote.
Yeah.
We vote to continue and.
So we'll need to,
Drew wanted us to take a vote, so the vote is to continue as, I mean, it sounds like
But we can stipulate that it's.
Until the matrix.
so we have, I guess we need a motion then
Through the
to
end of the-
continue.
To the end of the calendar year?
Yeah.
Do we make it?
Well, I have a motion out there to continue as we are on 6 until.
Oh, okay. Second?
Roll call vote, please.
Martinez?
No.
Miller? Yes. Palmer?
Yes.
Pettit?
Yes.
Wallstaff?
Yes.
Thank you. All right, so we will continue as we are until we meet again. All right, so let's look at item number 7. Board to approve or not to approve the following authorized representatives for Oklahoma County Finance Authority Educational Facilities Lease Revenue Bond Series 2020. Jennifer Fuller, Drew Eichelberger, and Kathy Draper Richards.
I move approval of item 7.
Second.
Roll call vote.
Martinez?
Yes.
Miller? Yes. Palmer?
Yes.
Pettit?
Yes.
Wallstaff?
Yes.
Anybody have any comments?
No, I would just reiterate, Coach Grumman, thank you so much. This is the type of information that all of us need to make decisions, and I appreciate you taking the time to put all of this together. I've got your zip code. I don't know if I can have this. You can shoot it to me.
just thank you to the principals and to Mr. Eichelberger for your work in all of this. It has been, it's a lot to do, so thank you for that. And also for the public, I know there has been some question about when we have school board meetings and how those are publicized. They are scheduled to have to be posted, I believe, what is it, 48 hours in advance? So those will be posted on the door of the administration building, and it's also posted on our website. Our regular meetings are the first Monday of the month at 6 o'clock. So it's not a secret that the way school board meetings work, we can only discuss items that are on the agenda, and we can only vote on things that have an action item listed for those. So just for general purposes, I thought I would share that. All right. Nobody has any other comments?
Move to adjourn.
Roll call vote?
Marquez? Yes. Miller?
Yes.
Palmer?
Yes.
Pettit?
Yes.
Walsh?
Yes.